Morning, everyone. Good morning, everyone. Morning. So a warm welcome to Warwick. Hasn't the year gone quickly? It's extraordinary. The good news is we're all still here. We have people from every continent, including Scotland. We know what the next 2 days is about. We've the opportunity to meet people again, to reacquaint with each other. We've got a fabulous programme covering the breadth of public health science and practice, and people that you would want to spend time with and to learn from. I have a dream that in the next year and the years after this, rather than have a Public Health England conference, we have more like an Irish gathering where we bring people together, because it's about a family. It's not about Public Health England, it's about the public health family. It's the whole system. It embraces the NHS, it embraces local government, the national contribution, the third sector, the voluntary organisations, and of course citizens themselves. It's a whole team effort. So rather than have in future years coming together as the faculty, or coming together as the Association of Directors of Public Health, but that we should. So I want to prosecute a discussion in the next few weeks and months about how we might do this once, but even better and together. Of course, without the alcohol, so you can see the scale of the problem. I have to convey appreciation and a thank you for what people have done in the last year, to honour and to respect the contributions that each have made. I'm inevitably going to talk about what we've yet to do, but if I can just focus for a moment on where we've been. Who would have thought that this nation could be reporting teenage pregnancy rates that have dropped in each of the 7 last quarters? Extraordinary. Did people believe that was possible 10 years ago? Do you? This is interactive. One-year survival rates are the best we've ever seen. From cancer, remarkable. Cardiovascular disease, we've seen improvements in from many endeavours of many over the years. Local government, who have embraced the new leadership role for bringing together the public health services, improving the public's health at a local level, have embraced this with rigour and with vigour and with excitement. The anxiety that existed about how would this go, would things be maintained, would we see a continual growth and improvement? Well, in our first year, I think we can say we've made a good and solid beginning. Drug recovery rates have been maintained. The health check programme has been extended. We've seen work from one end of the country to the other about preparing for the 0 to 5 transfer in October next year. Many of you will know that I spend much of my time out meeting people in the field. I've been to well over 100, maybe closer to 120 local authorities in the last 12 to 18 months. And, Newcastle's work with the homeless, Warwickshire, Leicestershire about getting people moving, addressing alcohol at a local level in Ipswich, in Bedford and in Portsmouth. Wherever I am in the country, the conversation begins with local government with an appreciation that economic prosperity is what drives good health. That the most important contribution that we can make at a local level for an adult is to get them into work and to have work, and how much that radiates benefit for others, and particularly for children. That well-being in the context of local government isn't just a phrase. What it means is, and how are local people benefiting? Getting high-value employment into an area where local people can't get the work is not an outcome that I'm seeing local government pursuing. It's both. Economic prosperity, the creation of jobs, inward investment, and everything associated with that we know that really, really matters to improving health. Decent housing, educational attainment, companionship and friendship for people who are isolated. These are all being driven by local government. None of this on their own, but as the natural leaders for place and for people. National government have got a lot to be feeling good about. Who would have thought we'd have made the progress on standardised packaging? We're not there, but we're almost there. Smoking in cars. We'll come on to where we haven't been able to make the necessary progress or where we want to be, but we can look to see real progress. We've launched an exercise, Getting People Moving consultation, very much supported nationally. Public Health England itself, we've launched 3 new immunisation programmes. We do this with others, particularly with the NHS. Many people in this room will be aware of the measles problem we had a year and a bit ago, where by collective action we reversed the Wakefield effect. And we reduced the numbers of measles cases in 2014 over the previous year by 90%. Extraordinary. Created and launched the world's most comprehensive cancer database. And we've been very active in health protection, more widely. Most obviously, most recently, in supporting the Africans in the Ebola crisis. And we have a team effort here, where we have people out on the ground in Sierra Leone, backed up by hundreds of people supporting them in microbiology and epidemiology and in all the different professions that come to make that contribution. So local government have made a fabulous start. I'm absolutely proud of the people that work for Public Health England and the way in which they go about doing their work and the difference they're making. And I can see a sea of support coming nationally for improving health and what's going to make the biggest difference. This was expressed in a letter from the Minister to me called a remit letter, which set out their expectations of Public Health England in 4 areas. Health protection, protecting the nation from infectious disease and other hazards. Improving the health of the nation. Supporting the NHS and building capability in the public health system. So if I touch on each of these. For health protection, from measles to Ebola. The work that our scientists and epidemiologists did around the nutritional feed problem for neonates saved lives. There are thousands of incidents that are being managed every day, not all in the same place. Every day around the country, just quietly being managed, keeping the country safe. This isn't all about Public Health England, because 90% of these incidents are managed locally, but we have an involvement wherever we can help. It's hugely important. It's like MI7. Nobody knows where the headquarters are. It's hugely important. Very easily forgotten, but not by me. Is that clear? Health improvement. Improving the health of the nation. Notwithstanding the improvements that we've seen, and I know these things take time, but we need to be ambitious. As we speak today, there's a 19-year difference, 19-year difference, 19-year difference in life expectancy between those that are the wealthiest and have the most and those that are the poorest and have the least. And typically, that gap is around 10 years. And even in the wealthiest areas, the gap is present. The density of that gap is different, of course, but in every part of the country, we see these gaps. And the most striking thing about what drives the difference are the risk factors. The risk factors that affect the length of life and the quality of life when you're alive. And those risk factors are driving our thinking about our contribution over the next number of years. Not led by or driven by, but we're part of what we do about this as a nation. And those risk factors are driven straight from the evidence. We're going to hear later this morning about the work on the global burden of disease, but also the work of many on social determinants and about what drives outcomes. The number one risk factor remains tobacco. Tobacco remains the nation's biggest killer. Notwithstanding everything that's been done and the progress that's been made, and it has definitely happened, it still remains the biggest killer. The second most important risk factor affecting premature death is blood pressure, hypertension. I'll come back to this. The third is factors associated with diet. The fourth are factors associated with not taking enough exercise. As you see, I'm moving around. And the fifth is alcohol. And alcohol is really interesting. You know, alcohol is the leading cause of premature death for working age adults. It accounts for 1.2 million admissions to hospital every year. The cost to the country runs into the billions. But if we take those risk factors, what's so exciting about them is that we all know about them. And they are the same risk factors, whether we're talking about cardiovascular disease, dementia, diabetes, or many of the cancers. So rather than think about conditions through a public health lens, to think about the risk factors and what more could we be doing? What more can be done to mitigate those risk factors? People have choices. There's an argument that rages internationally about what proportion of all of this is about the choices people make, the behaviours they exhibit. So I'm going to be conservative and say it's 40% to do with the choices that people make. Then there are environmental factors, genetic factors. Do you have a job? Do you have enough money to live on? Do you have somewhere to live? Do you have friendship and companionship in your life? This is what drives my comment about these are the things that drive good health. Where there's still an argument raging, again, there isn't an agreement on this internationally, is what's the contribution of healthcare to good health? I'll be conservative and say the contribution is 20%. Many would argue 10%. The point to this, and I know you know this, is about how we together and with people, citizens, people living in places, living lives, in real places, real lives. About how we reach them in ways that have relevance and meaning to them, which I'll briefly return to in a moment. So those risk factors that affect length of life and good health, and how we address them, and how looking ahead we'll do even better than we've done looking back. Driving 7 priorities for Public Health England, that what we want to do is to work with you, with government, with industry, with people, about what can we do? What can we do about these? We know that the best start in life is the most important contribution we can make for the rest of life. So I was talking about what's the most important thing we can offer an adult for their health is to have a job. For a child, it's a good start to life. It's the beginning of life. There is no disagreement about this. I have 3 children. I may have done this with you. 2 of them are teenagers now. I'm explaining that the brain develops at a huge rate in the first 2 years of life. It then slows down a bit. It then all goes mad in the teenage years. And then it's all over. So I have a 14-year-old, almost a 15-year-old, and he goes, stress. I can't quite do it. It's sort of very dramatic. Goodness knows what the school's teaching. And all I've said is good morning. But you get that, don't you? So, but the most important priority, and the one that Michael Marmot said, if you did nothing else, do this, is sort out the beginning of life. Now, we do this for many, but not for all. And the opportunity that exists with the responsibility for improving health resting with local government, it's a citizen responsibility, a population health responsibility sits with local government, is to take all the assets that exist, everything they've got, and what we're going to be giving in health visiting and other resource to do with 0 to 5. And there are 2 metrics that will matter. The first is every child having a good start. That means looking after mum. Now, inevitably, I'm going to think dad matters, but even I've got to seed that. So it's pre-birth, first 2 years of life. The second most important for children is them being ready to learn when they start school. Not through the eyes of a public health professional, but through the lens of a teacher. So the conversation that we'll be having with you, prosecuting night and day, and when you're fed up of it, we'll double our effort, is about children having a good start to life. How can we make sure that when we're having this conversation in a year's time, and in 2 years' time, and 3 years' time, we can show real progress there? Not at population health level, but for children named living in places. Then I take the risk factors. We dream of a tobacco-free generation. We need to keep focused on tobacco. And I say we've got a lot to feel good about. We need to keep going at that. It's the nation's biggest killer. Children start to smoke, adults don't. It's a child protection issue. We need to keep focused on it. Obesity, particularly obesity in children. 1 in 3 11-year-olds, as we speak, is overweight. Now, I have a particular issue about joining together overweight and obese. I don't think it's helpful. There is a difference. But 1 in 3 is way too many, and something goes wrong, badly wrong, between the ages of 5 and 11. So 1 in 5 children aged 5 are overweight, and that becomes 1 in 3. come 11. So we know that, if I go back to the risk factors, that children aren't moving as much. There's a spurious accuracy to this, but if we went back 50 years ago, children are moving a quarter, they were a quarter less, or they were, maths is not my strongest, but, everybody's slowing down. Even the Chinese are slowing down. The work that's been done around the world, everyone's slowing down. We need to find ways of getting people active again. You'll have seen that we've been very much involved in discussions about the contribution of sugar. And this is obviously a factor. It's of course not. There's never a silver bullet. Do I need to state the obvious that there's not a pill for this. We will have to work with a range of factors. What's in our food, how much of it people are taking in, and how active folk are. But what's so exciting about this is doable. It's not. We don't have to discover it. We've got to act on it. Alcohol. Well, I've mentioned some of the horrors about alcohol. This is the one long-term problem, if you like, that's going in the wrong direction. So although we can show that we're making progress on tobacco, even on childhood weight, we're seeing it levelling off. It's just at too high a level. But with alcohol, it's going in the wrong direction. And we're seeing that through what our hospitals are having to cope with in A&E and in admissions. I was in Sandwell yesterday morning, West Birmingham, the acute hospital, and with the council, Sandwell Council, and they were showing me that of the alcohol-related work that they do, 20% of the activity and a quarter of all the admissions are accounted by 50 people. Now this is the public health analytical strength coming to bear about. It's brilliant. We'll get a personal plan in for each of the 50 and transform the experience of that hospital. This is the first hospital that I've been to that has a published public health plan. I'm familiar with other places that are doing great work in improving the health of their people and their wider contribution. Barts is another, Oxford Radcliffe. But Sandwell have really taken this on, and their biggest theme is alcohol, because it's driving them. It's driving them to distraction. We've been asked by government to give them advice, evidence-based advice on alcohol, which we're working on at the moment, and with some, if not many of you in the room. So we will be coming back to talk more about price. We'll be talking about getting a health objective into licensing decisions, about what the NHS can offer, how we work with schools. So in this theme of alcohol, there's a lot to do. But we've been asked to give our best advice, and that seems to me the right next step. So we're working on that at the moment. Dementia, I've touched on as the risk factors all being important for dementia. We have, just short of 1 million people with dementia as we speak, with an aging population, and with health not being so great, we'll see that increasing over the next 15 years. I said I'd talk about blood pressure again. It's the second most important risk factor affecting premature death. For Alzheimer's, 80% of Alzheimer's has a vascular component, blood supply. And all dementias, it's around about 60%. The important thing is this is amenable to prevention. It's amenable to intervention early. It's not inevitable. We can delay or stall the onset. Think of a world where we could say, that we had delayed the onset of dementia by 5 years, because we got good and early diagnosis, and the interventions were about how we mitigate the risk factors. So I'm after a tobacco-free generation. I want to stop 15-year-olds taking up cigarettes. We need to be hugely ambitious about alcohol, but we'll come back to say what we think that should be, but it will be ambitious. We should delay. We should be seeking to delay and mitigate the onset of dementia. We need every child to have a good start to life. We need to be doing something about the weight of our children. 2 other areas. Tuberculosis. Did I mention this last year? This time, this year, maybe next year, but within the next 12 months, we will have more new cases of TB than the whole of the US combined. And about 15% of those are drug resistant. Hugely difficult to treat. We'll be talking today about an agreement that we've reached with the NHS England, to really go about addressing this and to take it out of England again. There are about 6 parts of the country where we have our greatest difficulty. Half of the cases are in London, but Manchester, Leicester, Birmingham. And a collective NHS and public health response to tackling tuberculosis with real new investment. Antimicrobial resistance is the 7th. And we're leading on 4 of the 7 components to the UK plan to make more sensible use of antibiotics, to discover new ones, to make more sensible use of the ones that we've got. So those are our 7 priorities. Did they add up to 7? Is anybody counting? I'm pretty convinced that's 7. None of this we can do on our own. None of this is amenable to a silver bullet, but it can be done. And the way that people said 10 years ago, there was nothing we could do about hospital-acquired infection, teenage pregnancy, people say these things can't be done. Well, we want to set stretching goals. We don't want to cross the stupid line, but we want to be in a place where people see, I'm quite comfortable being in a place where people say, we'll believe it when we see it. The thing is that I'll be doing it through you. So it's how we do this together. How everybody makes their contribution, wherever they sit in the system. So we need to keep the country safe. We need to improve the health of the nation. How will we know we're doing it? Because we're closing that gap. We're tackling variation. We're spreading what we know others have done and it's worked. We're holding the mirror up and we're showing each other, so how are we doing? And we're unrelentingly, without apology, talking about it all the time. A good start to life, and within that, children be ready to learn when they start school. We mustn't have our 15-year-olds picking up cigarettes. We have to do something about reducing the burden of alcohol. We need to get our children moving. We can't carry on. We certainly can't be complacent thinking that because the weight gain has stopped growing, that's all right, because 1 in 3 and 11-year-olds are overweight. That's not all right. Dementia is something that we can tackle, and we must. TB is an embarrassment, and antimicrobial resistance is a global concern, but the UK has to play its part. I've touched on the importance of place and people, the leadership that everyone brings. Transparency, big data, showing people how they're doing, getting it out there, freely available, everyone can see. I used to think that hospital sisters were competitive until I met local government. So, you know, just getting information out there and saying, so how are you doing? And it's not a shaming thing. It's about saying that others are doing better. What are they doing that you might do? What can you do? The most exciting thing, I think, for us to be in is in the behavioural sciences, in the digital age. To be in a space where we're working with academe, we're working with the social scientists, we're working with the people who know about how you get to people and touch their lives in ways that have meaning for them, that are closest to them. It's often the local organisation. It could be the faith group. It could be the local charity. And by condition, by age, by geography, we are enriched as a country by the third sector and the voluntary sector, whoever it is that can reach people and hold them. So part of what we'll be talking about in the next short while will be how we could run a competition with academe to partner academe in the behavioural sciences in the digital age, to reach people in ways that have meaning for them. We're used to running competitions in the biomedical sciences. I want to run a competition in the social sciences. Time doesn't allow this morning, but honestly, the opportunity here is awesome. Just one sense is Asda have 22 million customers a week coming through their doors. 80% of all grocery shopping is through the 4 major supermarkets. They have more customer insight than we could ever dream of. We believe we know a lot, but they know more. How could we join up in the digital age? Platforms they've got about how their people are doing. They want their customers to live. For as long as possible. We're going to, we've been puzzling a lot, really thinking hard about how do we express this in ways that aren't all about what government has to do, or all about what legislation can offer, all about, you know, hitting people with sticks. And how we express this in a way likely to get traction with local government, with the NHS, and with people themselves. And where we've got to is we're going to write up these 7 themes, and we're going to write up the, if you like, the game changers, the things that will make the difference, the behavioural sciences, the place-based approach, the big data, the digital age, and put it into a written form that we can then work on with you over the next few months. And we'll publish this at the same time as the NHS is publishing its 5-year plan, with a common front from the NHS and from ourselves about the importance of the risk factors and the importance of prevention and early intervention as the narrative, if you like, for the NHS of the public health system. So look out for that at some stage in October. But no, it's not the end of the story, it's just the next stage. And hopefully this conversation this morning sets the context for that. So can I end with my heartfelt thanks? I tell you what's different this year is I can see you. Is this? Because last year when I said, you know, I want to say thank you, and I'm looking at you, and I said, I mean you. And I was looking at a room full of darkness. But I still think I managed to point out someone and said, I do actually mean you. Yeah? There's a lot of cheesiness about this sort of stuff, but not from me, it is heartfelt. I am astonished and inspired by what I see and the difference that people are making. We've made a good start. We need to do better. And we will. We're going to spend the rest of the time, if I've allowed any time, for questions. Do we have time? Do we have time? So would anybody like to ask me anything? I think I remember saying to you that I spent 11 years in psychiatry, so I do silence.
There we go.
I think we have a question at the top and then through to you. Yes.
Good morning, Duncan. It's Tom Malarkey here, Chief Executive of ROSPA.
Yes. Hello,
the Royal Society for the Prevention of Accidents. Duncan, you've mentioned the third sector, and we do think we have a part to play. There's a lot of stuff that goes on in public health that isn't done by Public Health England. Yeah. And in many ways, ROSPA is an additional department of Public Health England with a big role to play. Would you like to say something about the third sector and how we can help to make your very laudable and quite rightly ambitious vision come to fruition?
Well, Tom, I couldn't but honour what the ROSPA offers, and Tom has been to see me to talk about the leading cause of disability and being about accidents, and particularly in children, and about how if we could bring to bear everything we've learned about keeping people safe in a particular geography, how this would show direct impact on reduced attendances in hospital and in primary care. And the history, if you like, where we've been has been to look at the world through a biomedical lens. This is what I'm trying to explain, that we need to continue to do that, but we need to do more than that and look at it through a whole range of other lenses. So when we talk about the burden of disease, of course, having an accident isn't a disease, but it's a huge cause of preventable injury and death. So I'm glad to have you as a department. I'm not sure I could afford you, but we are together. We're a part of the wider spiritual family, and I look forward to this sort of partnership as the sort of wider contribution, bringing together the wider family. Yes.
My name is Felicity Smith. I'm from Faith Action. We're a national network of faith-based community organisations. You talked a lot about place-based approaches about delivering these priority areas, which is your speech was fantastic, by the way. I'm just wondering how you are planning to use kind of community venues and even faith groups for doing that type of work. Have you thought about that yet in terms of using the community kind of assets that are already existing to deliver these messages?
Well, you're doing it now, of course, aren't you? It's just the rest of us have to recognise.
I'd like to think so,
yeah.
Yeah, that's partly why I asked the question.
And I've been in places, I've been introduced to people, to families, to characters all over the country who are doing it now. And often holding people better for longer at a fraction of the cost. And the idea that I used to think when I worked in a specialised mental health service, somebody would talk about a complicated patient, and we'd stick our arm up and say, that must be us, complex must mean us. And now I'd keep my arm right down, because I'm more interested in knowing, so who's got traction, who can, this bit about relevance. I'm not talking about hug a tree. I'm talking about the evidence that drives good health. So faith groups are, an awesome contributor, and you're doing it now. We can get closer to you, I think, about getting evidence to you in ways, materials, tools, things that you can make use of, and we are completely committed to that. So we'll just keep talking, and till we get it right. So I'm being told I need to end. We're together for 2 days. I meant to say at the outset that we don't have the Secretary of State with us. He was delayed in Africa. His plane stopped working. That's the technical thing. He was on the phone yesterday from Nairobi. It's like really unintentional. And he really did, because I was talking to him as recently as Friday about what he would cover. So apologies from him, but no apology at all for having Jane Ellison, who's our public health minister. And Jane's going to step in and to talk to us just after lunchtime.